That's actually an excellent statement. Yes, can I steal that? I have not made the leap of actually just phrasing it specifically like that. That yes, if you take the time and use extra positioning and bolstering to the point that the symptomatic area is as non-symptomatic as possible, then yes, effectively you are doing positional release. So why in the world, why not do that?
Right.
So yeah, excellent point. So, in the prone position, bolstering that will help you just access the stuff better, and 2, make it safer, make them more comfy. If they have low back symptoms, this is worth seeing if it helps. And if it doesn't, hey, we can remove it and it's fine. But getting that underneath of them when they're already laying there is way more of a journey than just having it there. So I would nice if I could do this for somebody, but that's not usually the case. The position of this, remember you want it kind of belly button and down so that the hip joint is flexing and the pelvis is lifted. We want the hips flexed and the pelvis lifted. This will create some space in the lumbar vertebrae. It also takes, at the very least, the hip joint, takes it out of full extension and puts it in flexion, which is going to be a looser pack position for this joint. So even for hip arthritis and stuff like that, wow, what a thing to solve so many problems. Now, when I'm here, some of the assessments, and that's part of it too, yeah, as I can find my way of talking through all of this, is ideally you have the time to do the full functional assessment and have them stand in front of a pane of glass with lines so you can see all the asymmetry and everything. If you're in private practice, it's maybe is something worth considering of having a little bit of extra time with your first time clients so you can do these assessment things. But man, I had to get really good at watching people get out of chairs and walk down a hallway and then doing on-table assessment. And with first-time clients, if they had symptoms, if their goal was therapeutic change, then I'd be coming in, like we'd have our verbal dialogue as I got them down the hallway and in the room, but then as soon as we were actually making contact and doing the massage, I'd be chatting with them about what was going on. And prone position, whether it's the best starting position or not, whatever, it's the most common one. So we're gonna start with that as our point. When I'm here, you know, I think you've heard me say, a lot, I think of what I'm doing is making my assessment feel like massage. You hear Sandy say more massage is assessment. So you can kind of layer all this, but ultimately, why not be doing something, even if the goal is just purely something that feels good, while I'm thinking about what the heck to do next. But we get to layer our therapy, ideally, in this. And something too, if a person has a lot of, you know, pain-related symptoms, their chemical soup is more in that stress, sympathetic, aroused place. So a massage that is purely therapeutic and intense in sensation is also going to be more sympathetic, autonomic nervous system related, right? So you gotta try to balance the chemical soup out sometimes. And I had plenty of a case where I had a client that is a mess, and I'm like, hey, we gotta at least have 10 or 15 minutes where you get nothing but a really good hand and foot massage to just kind of balance out those chemicals. I gotta, so you can even think like that? Yeah. Now the assessments we have here, a person's laying there on the table, and I have this. We're gonna start thinking about neck and shoulder, but with all this, I'm gonna initially create kind of a layer of how I can look at all of this kind of as at once, and then we'll get more precise, all the way down to whoever wants to be a body. If you have any of these issues, donate yourself to science. So, person is laying like this, if that's our starting position. No, they'll be like that. There we go. So, are they laying crooked? And is their crookedness correlate with their symptom? The one I know we practice the most and just the easiest initially to get your hands on are these scapulas. And you can make it feel good. If there's a nuance here, it's that you're watching not to tickle an armpit too much. So when I'm grabbing a hold of the scapula, the inferior part, I'm coming down here, trying to keep my fingers pretty broad and flat. And you guys have learned this, but that ends up being a really important part with getting into these smaller spaces, is stabilizing your hands correctly. So before I get too far, it's there's sloth claw, but then there's, what would I call this? A stable paddle. 2 stable paddles. And I live like this. The palm, I have this as a wedged soft fist. That can sometimes fit in better places. Ideally the forearm, but in some of these areas, I gotta use fingertips. And especially when just trying to be a bit more precise with the amount of pressure, certainly starting out, you're gonna have better palpation sensitivity with your fingers and hands. But protect your fingers and hands. Don't do it. Don't do it. I know you want to, but try to leave your thumbs out of it. Try to turn your paddle into your thumb. And my pressure is mostly focused at the middle and ring finger. I bracket those between the index and pinky to give them stability, and then I flex them a little bit, because I have even a hyperextended, hypermobile middle finger. So if I do pressure like this, that kicks back and isn't a good time. So paddles, and then sometimes stacked paddles, where this hand is predominantly palpating and finding the spot. And then I let this hand come over and actually be the pressure giver. That's how you can just try to be a little bit more precise, especially with this graduating your pressure by, we're talking probably just a few grams, right? It's not pounds, it's the tiniest bit. And not hurting your hands along the way. Okay. So, in this position, hands on scapulas, finding those inferior points and just comparing your hands. And while I'm doing that, I can kind of be rocking back and forth and making this feel like a good massage. But I'm just getting a hold of those thumbs along the medial border and then comparing contrast. More often than not, the shoulder that's elevated is the bad one. It's the wrong one. So pretty common for that to correlate with the dominant arm, but the scapula that's elevated and protracted, and especially the one that tends to get winged, that tends to, doesn't mean it can't surprise you, but that tends to be the symptomatic one, okay? So let me grab one of my models here. So we got this one right here. Oh, no. That'd be quite the, how'd you get like that? So they're laying here, and this one's up and over. So I'm feeling, and there's usually something else, they're laying there odd. And so I have to check in about comfort. What can we do to get them more comfortable? Now, with the shoulders, that can sometimes be a journey. Here, that's where change the face cradle, maybe a pillow at the chest. This is usually okay-ish, but sometimes it may be worthwhile to just limit your time in prone. If the shoulder joint itself is not the problem, and typically even if this is the thing, getting at least out to this position is not problematic. And it is just usually a bit more comfortable here for the actual ball and socket joint, but you don't want to rely on that purely as your assessment. Usually get them here in kind of a, although they're pronated, call it anatomical position, because they are a little bit frozen against the table here. It gives you a bit of an objective assessment. And usually a person is laying crooked because that's how they tend to lay in order to get comfortable in the first place. So just getting a gauge on this and going, well, I'm going to initially assume that that's an exaggeration of how their muscles are holding their body. And so crooked scapulas, okay, I can get usually a more honest read here, and I can adjust their shoulder girdle because I can just make the massage feel like working on that levator scap upper trap area. But part of what I can be doing there is mushing that scapula down and confirming that they're down as far as it feels like bind will allow, and then I can get an accurate read comparing contrast. Pelvis, same thing. When I'm standing there, they're off. It really shows itself, right? So we'll come more to that. Positioning of the shoulders out, and then comparing. Did that already change it? If it's just position that's causing the asymmetry, then that could be part of your formula. And if I bring them out here, they're more comfortable and suddenly they're more symmetrical. It's like, I'll figure out what's going on. Their shoulder only really seems to go into asymmetry when it's down in adduction and an extension. And suddenly I get them here and everything's fine. If you can just find a way to be more precise with like what's going on, I go, well, probably pec minor. I'm gonna go after it if you're just like this. And as soon as I bring it out here, it's fine. Okay. With arthritic shoulders, this would be too big, but do be aware that you want pillows, towels, anything to sometimes give a little cushion here. And it depends on the person, depends on what's going on there. They may find they're more comfortable laying like this versus the arm off to the side. You know, but the pillow somewhere holding that shoulder joint in a better position can help so much. Down here, now when we do our massage, I start here, come up, chit chat. You're a neck and shoulder and low back person. This person has every issue on the board. I can be palpating along, coming up, and nice thing too, all this can start off feeling really like nice and gentle. Working on the neck in prone is fine, just make sure your face cradles are tightened accordingly. And you're never going to be applying a lot of pressure, but palpation assessment, drawing the hands, not too delicate so that you're not tickling somebody, but following the spine, because you can find those spinous processes, and even if they're super muscly or something, you can see that valley and give that an assessment. We're coming up to the base of the skull. And that's where some of the extra, you can get into all the various bony landmarks, but ultimately the bony ridges and bumps are going to be more or less symmetrical on one side and the other. So to try to just dilute this and make it a little bit more simple, it's make sure they're relatively still and find some kind of process or cavity on both sides, and then start working your way delicately around there. One, you'd be surprised at how good that feels. It's kind of like long holds, light pressure, but this whole time I can just be doing a little bit of an assessment, either feeling tone, but also feeling how well does this side move? How's that connective tissue doing on this side versus the other? There's a huge ligament that runs like this, called the nuchal ligament. Runs from the base of the skull down to C7, and it keeps you from being a bobblehead. If you didn't have that, it'd be a bad time to have this big of a skull and this tiny. So all of this can be correlated. It can be a little bit of grabbing here, neck massage here, but predominantly come up to the base of the skull, and this would be a real telltale moment. This is the angry shoulder. This is the elevated shoulder. And I feel extra tone at the base of the skull on the same side. I can be like, oh, levator scapula and upper trapezius. You're probably part of this because you both come from the shoulder, levator scapula in particular, that superior angle right to the base of the skull. So you can see how one getting offset for one reason creates an issue here, or this creates an issue here. So also, that's a spot that everybody likes getting worked on, right? Never gonna be a bad time. All right. Assessment down here. I know the part that drives you crazy. So once here, one of the biggest issues with the assessment of the pelvis is you're never usually able to be directly in line with them. Like, yeah, I could climb up on the table and go, but that's not usually the, you know, the kosher thing to do. So, and to lean right over top of a person, do it this way is also odd. So, when you assess anything related to the pelvis, walk around the table and do it on the other side too, to make sure that you're just not getting a crooked read because you're crooked. So if I'm here and feeling, and I know there's plenty of people that are practiced and do pelvis assessment in prone, I'm actually not that big a fan of it. I would rather just save a lot of that for supine. But getting some kind of a gauge on at least a few key structures. One, is the tone really crooked? Yeah. So is the tone really crooked on one side versus the other? Okay. And when massaging, how lateral is it? Is it the erector spinae versus is it something more over here? And that'll usually be what a person says too. Like I draw some lines on the body with people. I'm like, is it more here, more here, more here? Between those three, I usually can zero in on at least a causal component of their symptoms. It may not be related to the source of the problem, but so up and down here, probably more erector spinae. Down here, SI joint, more one side versus the other. The term that I use is the lateral raphe, but what you want to call it is the quadratus lumborum technique, or QL release. It's one of the deeper structures here on the lateral side of the spine. So honestly, we're probably also interfacing with the obliques and other aspects of like the lumbar dorsal fascia and a lot of things that come in there. But if you see techniques out there about quadratus lumborum or a QL release, it's going to be about interfacing with the lateral side of the lumbar area. And that is an important part, especially when it's one side versus the other.
When you say is the tone really crooked, is that something you're seeing or feeling?
Seeing and feeling. That's a good clarification. Sometimes you can actually just see that there's more muscle tone. I don't see that too often, but every now and again I can see the erector spinae on one side. It's like, wow, those are definitely engaged. And then palpation. Predominantly, our gift is palpation. So compare and contrast, connective tissue pliability, all of that. And where the connective tissue is more taut, more bindy, that's almost always going to correlate with extra muscle tone as well. So the tonal factor here, the kind of just general crookedness of the whole thing here. And palpation wise, I can get real precise like this, but I'm trying to get you guys ready for your first time clients and come over and be like, it's just not usually the more comfortable initial thing. So here, usually what I'll do is something more like this, feeling with my palm, and maybe a little bit, but you have to learn to palpate this. So you're gonna palpate on each other. I am at a point now where I come out with my forearm while I'm working here, and I'll feel and compare this side to that side using the forearm application. But when you're learning this, you got to kind of get a clear sense of these smaller parts that you're searching for. I mentioned there's smoother ways to do this. Like I can be here, use my forearm to feel, I'm more on the sacrum along the SI joint. Let myself track a little downhill. I'm like, what's the tone of these things? How's the connective tissue there? And then I'm going to jump over and get on glute maximus and compare and see. With the athletes, sometimes it actually was glute maximus. They were actually just way too strong there, and their butt was pulling their low back down. When they were too strong in the right way, we actually had to settle that down. Now you won't see that too often, but But that's where it can be less of and turn more into it all feels like massage. So, I had a profound thing. Yes. One of my easier assessments here of the low back stuff is the rocking. Using rocking in some kind of rhythmic joint motion application in general, I'm a pretty mechanical practitioner, and so I struggle with flow. And I learned from my mumsy, who is also, a bit more on the therapeutic side of things. So from her, mostly, I have taken the rhythmic joint movement oscillation piece as my transitional technique. Like I make contact, and it can be the way I start things, but it's almost always the way that I end things. That I come in, and with the low back, if these structures are super tight, then they won't allow for free motion here without taking this along with it. So I know that the erector spinae and other structures related to the sagittal plane, i.e. psoas, are really tight if I take a person and move them and they move like this. If I try to just rock their pelvis. But, palm, not real low, just at like L5S1. Doesn't have to be big, because it can be subtle. I'm just like, it feels like I can roll them way more this way and not at all this way. Like, something's too short and tight on the right side. But I find that by doing this. Just roll that pelvis around, and if they rock like that, I go, well, somebody really glued you together. So, if the pelvis is more free moving, and I don't see it affect the rest of the body, then I have to get more and more precise. So usually the assessment is easier when the symptoms manifest more bigly, more profoundly. Yeah, that's easy there, right? Rocking rhythm, moving our way up. Even with this, the scapular movement stuff, getting a hold of that and kind of just rolling it around, comparing that side to this side. And then here, this position for the shoulder, when I'm applying compression and any kind of application to the triceps or deltoid, the posterior compartment of the upper limb, God, I'm going to get that inadvertent rotation. So I really don't like working on the upper arm in this position. I think it pins the shoulder in a weird way. I have a better chance of hitting the artery and nerve. I don't like it. So I put them here, and I will be doing a couple things. It helps me transition, because I'll go from this part with my forearm on the rhomboids and upper trap, with my hands right here to move that around, create some friction here, and then I smoothly transition to here, work my way down. And as I am applying just massage to the triceps, I am feeling this shoulder, there we go, is getting rocked back and forth. And then I can compare that to how well this one rocks back and forth. And I keep on trying to solve the mystery.